And with that in mind, it's an absolute pleasure for me to be able to invite Dame Anna Dominiczak, Professor Dame Anna Dominiczak, who is, of course, our Chief Scientist for Health. But that speaks very little of an extraordinary curriculum vitae. Anna is Regius Professor of Medicine at the University of Glasgow and, of course, Chief Scientist for Health now for the Scottish Government. She was recognised by Her Majesty with a damehood in 2016 for services to cardiovascular and medical science. Her background, as many of you will know, is in the conduct of world-class cardiovascular research. And over the years, she has graduated particularly to an interest in how precision medicine principles could be delivered in the context of cardiovascular, indeed now across a whole range of diseases and disorders. And that was manifest partly in the extraordinary developments that she has pioneered in the Govan campus, the Queen Elizabeth University Hospital campus in Glasgow, but now I have to say manifest with her energy and commitment right across the country. Her achievements are extraordinary and lengthy. They're contained a little bit in this slide that you're seeing in front of you. I'd particularly highlight the remarkable role that Anna played in her work in the Department of Health and Social Care and in really creating a lighthouse facility here in Scotland, which was, I think we would quietly say, a remarkable contributor to the response to the pandemic, and I think led to many lives being saved. Anna, it's an absolute pleasure to have you joining us today. I'm going to hand the baton to you and look forward to listening to you. Thanks ever so much.
Thank you, Iain, for this over-the-top introduction. As they say, it's only downhill from now after all this, but thank you so much. I'll try to make sure that I can share the slides, the technology. I hope you can see it. Can you? I hope yes.
Yes, we can.
That's
Anna.
great. It's looking great. Thanks.
That's great. So this first slide talks about innovation as an enabler of recovery, reform, and sustainability in health and social care. And it's that R&D and I, with the focus on I, that I would like to talk about today. And although my name is there is a huge and very talented group of people who have been working particularly on adoption of innovation that I'm going to have quite a bit of focus on for quite a while. And just before we start through the story, I would like to mention some important names, because this isn't like a research presentation. There will not be acknowledgement at the end. And these are Christine McLaughlin, who together with Tom Steele have co-chaired very early pre-COVID a group on which I sat in my previous Glasgow role, which was all about innovation adoption, this last stage of translation once for Scotland. We're going to talk about it. Behind them, there is a large group of people, both in Scottish Government, in CSO, in SHIP. David Lowe needs to be mentioned, but many others who have helped to make it real. And as I said at our CSO stakeholders meeting this morning, a Cabinet Secretary for Health and Social Care had a summary of these programs of work, this pathway of innovation on last Thursday, and was enthusiastically supportive. So we are changing, I think, the way we do things across Scotland, which is good. If I can change slides, which might be too much to ask for. Shobna, they're not changing.
Okay.
Is there something I am doing?
There must be an arrow somewhere down on the side of your slides, or your keyboard's not
Yeah,
connecting.
I've got the arrow, but it was too slow. Yeah, got
Okay.
it now. So as you know, there's a lot published. There are reports over the last few years about innovation and adoption of innovation, a lot of this with a focus on our NHS. But the same is about other health systems. This isn't easy. An early innovation, great research, plenty of it in Scotland, but to adopt something, to take it through entire translation and adopt once for Scotland is not that easy. We believe that now is the time, now is the opportunity for radical, perhaps even disruptive, as we're quoting here, innovation. And it is a necessity, not a luxury, of it in current situation we are in. And the challenge is great innovation, but it is all over the place. It's uncoordinated across our landscape. Sometimes we duplicate, sometimes it's in a wrong part of the innovation pathway, and that slows us down and makes it difficult to truly implement things. So what we believe we need is an innovation pipeline. This is a slide that tries to show it. I'll show more detail later. But all of us contribute. There is industry, academia, NHS colleagues at all stages of innovation, of course, funding agencies. And then, as you know, we have test beds in Scotland in 3 areas in the north, east, and west, which are not for one health board, they are for Scotland. And that's where we would like to implement true entrepreneurship, work with industry, bring new ideas. I've been working with economy colleagues and with Mark Logan, Chief Entrepreneur for Scottish Government, and we have come up with a recipe in which health in Scotland could benefit the same way as other areas, for example, fintech, and that would be great. Then we, of course, have all our national health boards who are extremely important in this work, and territorial health boards where it needs to be adopted and implemented. So that's the pathway. You know about the Scottish Health and Industry Partnership that was funded during the pandemic by my predecessor. The idea is to work closely with Division of Economic Development, the Directorate, work with economy colleagues to bring the economic growth, job creation, to bring benefit. As you know, health is an enormous part of our national spend, but there is also ability to create growth and create more money for Scottish economy by the excellence of innovation in health. And this is something that is now ready for implementation and working together. We have worked very hard on priorities, and colleagues have developed the demand signaling plan. It's still quite high level, and you'll see that these are things that are very, very obvious in our post-COVID legacy health service plan. But nevertheless, this demand signaling plan, we are told, is useful to industry, useful to young researchers who would like to adopt part of their activities, for example, their fellowships, of which in a minute, to contribute to this big picture. The idea is to work together collaboratively in this big picture. So this is what you all know. We need digital health, we need machine learning and AI, we need new medicines implemented correctly. We need to reduce the waiting lists, and innovations in this direction are hugely important for all of us. but we also need to think about multimorbidity and long-term conditions and better diagnostics, early diagnostics, particularly in cancer, but also in everything else. These are obvious priorities. Here is an early last year picture of what SHIP is trying to achieve, and I added in red new modifications, and I think it is important. Of course, we want to innovate. Of course, we want to work with industry, and we are invigorating currently our close relationship with life sciences industry through the Life Science Industry Leadership Group, but also through larger, bringing all industries active in Scotland, big and small, SMEs, pharma, diagnostics together. We clearly keen to have more investment and funding. This is difficult to come by, and maybe the way should be to use the money we have in more strategic and more focused way. I mentioned AI machine learning. There is AI Hub that is working with digital colleagues and becoming very important in every innovation in health that we look at. And I also mentioned test beds. But I think we can only achieve all this working with economy team hand in hand. And also that last part of translation, the adoption, this is now for colleagues, and I'm going to describe this in Innovation Design Authority and Anya to help and do. So we don't want to have everything in the same basket. We would like a continuum of collaboration, cohesion, and coordination across this pipeline. You, of course, know, and I don't need to remind this audience, that post-COVID priorities are very acutely felt across our health system, and the same is true all over the world. And in our thinking and demand and choosing where to spend time, we need to think about these priorities for our community. I mentioned test beds. These are very, very important infrastructures for us that host the ability for industry to try new things in Scotland, to think about Scotland as a place to come, to have near real-time health data that can be shared, exchanged, and used safely with absolute agreement of our communities, of our patients, of everybody involved. And I think this is where that work on entrepreneurship that we're starting now, which will be almost a school of entrepreneurship led by very good, very experienced people, some of them from the Harvard Business School, etc., helping us to really capture the best in the world in health innovation. I think that will be very, very important. The test beds, of course, are the material show of our ability to do triple helix collaboration, NHS, industry, and academia working together. This is how it works. This is how it has been from the very day zero of their existence. And I think this is something that Scotland can do better than others, even the systems that perhaps have more money, but we're really, really good at this type of collaboration. I mentioned fellowships. We talk a lot about the need for our young and not so young colleagues to have time, ability, funding to do R&D&I on large international competitive scale. As you know, 9 such innovation fellows have been already appointed, funded by the Chief Scientist Office. They are 3 in each regional test bed. They are relatively senior. This first cohort were people who finished their training. We have had discussion with industry and other colleagues, and the next tranche, which will be announced soon, will be at slightly more junior level. If there is a time for discussion, I would be interested what you all think about it. We think that this porosity with industry is sometimes developed better, not uniquely, but developed better if we start relatively early in life. And there are examples of very good fellowships and exchanges that we have seen over the years here and in the United States that were during the training period. So we would like to try slightly earlier stage of development of clinical trainees. Now, so to summarize what I have said so far before we move to the adoption and that last stage of translation, the key is the funding that we have for test beds and SHIP, the triple helix collaboration and partnership with industry. And I mentioned that we invigorating the industry partnership group, which will now have not only pharma, but also the diagnostic industry, the digital, and big and small. We've put very, very wide set of invitations to colleagues from industry, and we would like to come closer to listen carefully what industry needs in order to collaborate and bring funding, money, activity to Scotland. Now, on the adoption, on this last step, once for Scotland, adoption of innovations that matter for our community, we have managed to get some additional funding. This additional funding will help ANIA, Accelerated National Innovation Adoption Pathway, to really prioritize, select, and work very hard and fast, working with all these bodies that are in the center of my slide to evaluate and adopt ones for Scotland with appropriate preparation. You might know that there is a lot of work, and I think it's live now. The website Scotland Innovates, you see it here at the bottom. This is bringing the innovations from outside world, mostly from industry, but not only. And there is a system being developed how to follow this. But in health, the majority of innovations will come, we think, through our NHS colleagues, through academic colleagues, from industry, and very many through test beds. They've already been looked at, they already have been worked on and come to this last stage. The body that will be making prioritization and decisions is called IDA, Innovation Design Authority, and I have an honor and pleasure to co-chair it with Tom Steele. We would like to provide system leadership and coordination. We would like to make it matter. We would like to help select, prioritize transformative innovations. And particularly in these early days, they need to have the added value for our health service, for our communities, for our patients. And you see that we have worked very hard to bring colleagues from NHS territorial boards. You see here colleagues you know who are directors of R&D and I in 3 major areas, the East, the West, and the North. They do not represent their own health boards, as I said before. They represent Scotland on this group, on this board. This is just the beginning. I am working on bringing industry to this group. I think it's important that we're not afraid that we are talking closely to industry, but of course we need to be careful that there are no conflicts of interest and we work on the best way to implement this. So the pathway in detail looks like this. There is pipeline. I mentioned what in this pipeline and test beds and ship, probably the top level of this pipeline. We think the majority of transformative innovations will come this way. We will screen them. That's our orange stage. We then decide very quickly what not to look at anymore. We don't want to waste time, money, and people. We will do full strategic assessment and move to value case development. And then the national adoption at scale, not in one health board, in all 14 of them, and that's what it is all about. This is too small, but I just wanted to show you that there are a number of projects that are going through various stages of this process. The purple is the best, and that's where digital dermatology is. And I just wanted to show you examples. This is not a science that will be published in New England Journal of Medicine, Lancet, or Nature Medicine, and we're not apologizing for this. These are things that reduce the waiting times for our patients. So this is the digital dermatology referral. You're very much aware of this, really simple. Send a picture, you'll reduce the backlog by 40%. There will be action and intervention without face-to-face appointment in many cases. Very, very simple. We need to start simple. Technology enables theatre scheduling, very, very similar. University of Stirling looked at this study. It increases utilization of theatres by up to 35%. It's good enough to keep doing it. And please note that every innovation will have digital and data component. That's very, very clear. And the last I wanted to share with you, although there are many others, is this diabetes closed loop system for type 1 diabetes. You're familiar with it. Some health boards are already using it, others don't. We are going to very quickly check, investigate, and see why not. And the impact of doing it for whole of Scotland is very obvious to everybody in this virtual room. So in summary, I think our Chief Scientist Office R&D and I goals and expectations are summarized here. We would like to increase our risk appetite to develop and deploy transformative innovation. We talk about these burning platforms. This is really needed and needed now. There isn't lots of funding, and it's sometimes difficult to commit funding to R&D and I when budgets are under such pressure. But I think we have now evidence that this has to be done, and it's money well spent. We think that working closer with industry and listening carefully to systemic challenges that industry is posing at every meeting we have with them is very, very important. And that triple helix partnership that Scotland is so good at will take us really far in this program. And I think COVID-19 legacy, hugely important too. We learned that we can mobilize data, industry colleagues, academic strengths very, very quickly in necessity. And we hope that this Innovation Design Authority will bring it to bear. We will not go backwards. We will live and use COVID legacy in this work.